2 days back in a meeting with WHO DG. He was there. And one question was raised there about the ethical matter. We get contract tracing, regarding contract tracing, which we have seen in Singapore.
Yes.
They are just following everywhere. So whether the privacy is a question, it's not or not.
So we will discuss that issue today. We'll discuss.
Yeah.
So hello everybody, Confederation. Greetings from Confederation of Medical Association of Asia and Oceania. Welcome to 38th meeting, which is live on various social media. So this is a meeting for the doctors as well as for the public. So the topic I'm going to discuss is, because two vaccines have been approved in the USA, the Pfizer one and the Moderna. So both of have the same, almost the same clinical implications. So I'll discuss one report from the CDC. Now, whatever I'm discussing, you can put it down that Moderna also will be the same. So this will help in all our fellow countries where Pfizer is going to come. So this is a document which has come from CDC. So this talks about Pfizer BioNTech COVID-19 vaccine. So this is, first of all, what is this vaccine? So this vaccine is a lipid nanoparticle formulated mRNA vaccine encoding the spike protein. Basically a messenger RNA vaccine. Spike protein only facilitates entry of the virus into the cell. Vaccination induces antibodies that can block entry of the virus. And EUA 13th December for persons aged more than 16. Now, what is this messenger RNA vaccine? A, it is not new in terms of technology. B, they do not contain a live virus. C, it does not enter the DNA, the cell nucleus. Therefore, it does not affect or interact with a person's DNA. This is the two types of vaccines. Above is a DNA vaccine. The lower is a RNA vaccine. In the DNA vaccine, the DNA enters the nucleus and then produces RNA. In a RNA vaccine, it does not enter the nucleus and it produces an immune response. Now, what are the recommendations of the Advisory Committee on Immunization Practice? So they said for persons aged 16 years of age and older, whom should be given? Healthcare personnel. Residents of long-term facilities be offered vaccination in the initial phase of COVID-19 vaccination program. How do we administer? 2 doses, 3 weeks apart. Now what happens? Now see the tricky things which people will ask. They will say, second dose, 3 weeks apart. 3 weeks means what? Is it 21 days, 20 days, 22 days? So this is administration of second dose within 4 days grace period. That means 17 to 21 days considered valid. So you can give it anytime after 17th, 18th, 19th, 20th or 21st day. If more than 21 days have passed, second dose should be administered at the earliest opportunity. But no doses needs to be repeated. That means even if you cross 21 days, doesn't matter, give it. That means you can give it anytime after 17 days. Both doses are necessary for protection. Interchangeability, now there are some peculiar tricks here. They says they does not recommend interchangeable with other vaccines. That means Pfizer and Moderna are not interchangeable vaccines because the safety and efficiency of a mixed series has not been evaluated. But they now give a rider. This says whichever vaccine you take, second vaccine should be the same. However, if you have taken one and another one of the another company, no additional doses of either vaccine recommended at this time. This is by mistake. If you take Pfizer first and Moderna later is fine. Recommendations may be updated later, but at this moment they don't recommend. But if somebody gives two vaccines, then you did not repeat. So indirectly they are saying is that even if you give two separately, no need for repeating the third vaccine. Co-administration with other vaccine. They says 14 days before or after administration with any other vaccine. So it is not like pneumonia and flu, you can take it together. This cannot be taken with flu or with pneumonia. Other two pneumonia vaccines cannot be taken together. This is at this moment, keep a gap of 14 days. However, however, if it is inadvertently administered within 14 days of another vaccine, don't worry. Don't worry. See, there is always a rider. So these are the questions. They have made all the possible questions which can arise. People will say, oh my God, I took a flu and by mistake a COVID-19 within 14 days. Hold on, nothing to worry. Vaccinations, this is an important question which will come to everybody. Vaccination of persons with prior SARS-CoV-2 infection or exposure. This is persons with a history of SARS-CoV-2 infection. This is the commonest question which will be asked. Saurabh, kindly check, people are waiting. Vaccination should be offered to persons regardless of history of prior symptomatic or say asymptomatic SARS-CoV-2 infection. We have been saying there was no data, but this is data from phase 2 and 3 clinical trials suggests vaccination is safe and likely efficacious in these persons. Therefore, give it to everybody without checking their antigen test or an antibody test. So therefore, viral or serological testing for acute or prior infection respectively is not recommended for the purpose of vaccine decision making. Now, persons with known current, that means at this moment I am COVID positive, what should I do? Vaccination should be deferred until recovery from acute illness and criteria have been met to discontinue isolation. No minimal interval is defined. However, they are saying wait for 90 days. This is however, not a mandatory, but they are saying is wait for 90 days if you have, and then, so this is wait for 90 days. Persons who previously received passive antibody therapy for COVID-19. So currently no data on safety or efficiency in persons who received monoclonal antibodies or convalescent plasma. So this will be a common question. I received plasma, should I take it? Vaccination should be deferred for 90 days. Based on the half-life of therapies and evidence suggesting reinfection is uncommon. So all those people who said I have received plasma, wait for 90 days. Persons with a known SARS-CoV-2 exposure. So community or outpatient setting, persons with a known, that means he is a known exposure, but he is a contact, but he is not a patient. Defer vaccination until quarantine period has ended to avoid exposing healthcare person or other person during vaccination visit. Residents of congregate healthcare settings long-term Therefore, residents of congregate healthcare setting long-term care facilities may be vaccinated as likely would not result in additional exposure. Uh, Use adequate PEP. Residents of other congregate settings, correctional facilities, home shelters may be vaccinated. Wherever feasible, precautions should be taken to limit mixing of these individuals. So they are saying can be a vaccination of special population. Underlying medical conditions. Vaccine may be administered to persons who have underlying medical conditions, provided they have no contraindications. Now, this says phase 2 and 3 clinical trial demonstrate similar safety and efficacy profiles in persons with underlying medical conditions, including those that place them at increased risk of, so all comorbidities can be given. In fact, they are the main one to get it. Immunocompromised persons. HIV, other immunocompromised person who take immunosuppressive medications or therapies might be at increased risk of severe coding. Data not currently available to establish safety and efficacy of vaccine in this group. These individuals may still COVID-19 unless otherwise contraindicated. Individuals should be counseled about unknown vaccine safety, unknown efficacy, potential for reduced immune response, need to continue to follow all current guidance to protect themselves against COVID-19. Then they talk about pregnancy. No data at this moment, no live mRNA vaccines and pregnancy. It's not a live vaccine. They are degraded quickly by normal cellular process and don't enter the nucleus of the cell. Increased risk of severe illness, might be at increased risk. If a woman is a part of a healthcare worker who is recommended to receive a COVID-19 vaccine and is pregnant, she may choose to be vaccinated. So they are saying is all healthcare workers, if they are pregnant, they are recommended to be vaccinated, but with a rider, take it at your own risk. So routine testing for pregnancy vaccine is not recommended. This is an important observation. Pregnant women, that means if you are not sure about your pregnancy, you don't need to go for a pregnancy test. Pregnant women who experience fever following vaccination should be counseled to take acetaminophen or paracetamol. Breastfeeding, no data. They are not live viruses, not thought to be the risk to the breastfeeding infant. And if a lactating woman is a part of healthcare personnel, she should be given the vaccine. Patient vaccine counseling. Reactogenicity. Before vaccinations, providers should counsel vaccine recipients about expected local and systemic post-vaccination symptoms. Unless a person develops a contraindication to vaccine, they should be encouraged to complete the series. Analgesics can be given and routine prophylaxis is not recommended for such cases. Vaccine efficacy. 2 doses are required. Patients should be counseled on importance of completing the second dose. Public health recommendations for vaccinated persons. No vaccine is 100% efficacious. Therefore, continue your prevention guidelines even after that. They have not written for how long. There says protection from vaccine is not immediate. Vaccine is a 2-dose series and will take 1 to 2 weeks following the second dose to be considered fully vaccinated. Then these are contraindications and precautions. Severe allergic reaction, anaphylaxis. Appropriate medical treatment used to manage immediate allergic reactions must be immediately available. Therefore, it has to be given in the hospital setting. A severe allergic reaction to any vaccine or injectable therapy, intramuscular, intravenous, or subcutaneous is a precaution to vaccinate all the time. Vaccine provider should observe the patient for 30 minutes with a history of anaphylaxis and otherwise 15 minutes. Algorithm for the triage of person presenting for, that is precaution with proceed with vaccination, allergies. So they have given a complete allergy plan. This is for the doctors to keep it, that if there is a history of immunocompromise, pregnancy, lactation, everywhere they have given contraindication to vaccination. They say is none. If you have allergies, do not vaccinate. These are the ones which talks about it. Then now come to interpretation of the results. This is important. This is the most important slide. Viral test, prior recipient of the vaccine will not affect the results of the nucleic acid tests. That means after the vaccine is given, RT-PCR, if you are positive, you are positive. RT-PCR test will not be altered. Antibody test. Now, this is another question which can be asked. Currently available antibody tests for SARS-2. Currently available antibodies tests assess IgM and IgG to spike or nucleocapsid proteins. Pfizer vaccine contains mRNA that encodes the spike protein. Thus, a positive test for spike protein could indicate either prior infection or vaccination. So therefore, after vaccination, if your spike protein antibody is positive, So you can say either it is a prior infection or vaccination. Now, to evaluate for evidence of prior infection in an individual with a history of vaccine, then you should do the nucleocapsid protein should be used. That means if a nucleocapsid protein antibodies are positive, means prior infection. If it is a spike protein, that means it can be either way. Then clinical resources, these are the resources which they have taken. Infection prevention and control recommendation for person with post-vaccination symptoms. So they talk about, these are the references. Now here, these are the resources, yes. So this is what I wanted, because these are the questions which will be asked and applicable to any virus vaccine. So whenever any vaccine is introduced, I will come back with similar type of presentation. This presentation is for Pfizer to be replaced and synonymous with messenger RNA vaccine also. The Moderna messenger RNA vaccine also. When we have availability of Oxford vaccine or any other vaccines, we will come back with the similar guide. Over to the chair.
Thank you, President. That was a most enlightening, set of slides from the CDC and the committee that
CDC has sent a PDF. My team has converted it into a slides. If
Beautiful.
anybody want, then I can send the slides to them. This
Please
is a
do.
PDF. This is a PDF converted slides. Normally, the document has come as a PDF. So my team has worked out. So therefore, there are some mistakes in copy pasting. So this is what my team has done.
Thank you, President. We'll take up the offer. We'll take up the offer. We'll take up the offer of your slides. Most informative and very useful. Actually answers a lot of questions that we've been thinking about. And I understand that these messenger RNA strands that are injected into the body, most of them will last maybe a couple of hours to maybe maximum 2 days, and then they'll disappear. They'll be dismantled by the cells. So it looks like it's not as tricky as we thought it would be. So that's of great comfort. Because initially, all of us are very worried about these messenger RNA strands entering the nucleus and so on, mucking around with the DNA. Somebody did ask me whether it messes around with the mitochondria. Any thoughts, President?
No, they have said it is not entering into the nucleus, so there is no question of hampering the mitochondria.
Okay. Thank you. So
they have clearly said this does not enter the nucleus. So therefore, it is just a protein antibodies being produced in the cytoplasm. So there is no question of any genetic changes occurring because of this.
Yes.
Can I have a question?
Yeah. Yes.
Just one thing, actually, the question is coming for whether you need to do the antibody test before going for vaccination.
So they have clearly said no.
Yeah, no. So it's okay.
What they are saying is they are now telling us that if you are IgM nucleic acid capsid positive, it means in the past infection. But if you are S antibody positive, this can be the protein, this can be the vaccination, or it can be the vaccine, or it can be the previous infection.
Just can you come to just here this answer whether superiority of this mRNA over this adenovirus?
No, I'm not clear. Question, I'm not clear. Superiority of?
No, is whether there is a superiority of mRNA vaccine over the other vaccines, something like it's coming up.
So at this moment, other vaccines are not available, so we don't have a data to compare. They have not come back with a similar. See, the CDC has issued, after clearing, they have issued these slides. So once we have the third virus which is available, then only we will be able to compare. So normally the vaccines which are going to be compared is Oxford vaccine. They have not yet cleared their data to the public. about their, and they have not answered the way they have answered.
They are telling it's 70% effective.
No, no, effectivity is different. We are not even, we are discussing about other questions. How to check up for the antibodies, how to check up, can it be given to the secondary infection or not? All these questions have to be answered for each vaccine. So say, for example, in Bangladesh, you will have a choice of Oxford, you will have a choice of inactivated vaccine from China, or these two vaccines. Similarly, in India, we will have, instead of China, we will have a indigenous, inactivated vaccine, or we will have a choice of Oxford, or we will have a choice of these two vaccines which I have just spoken. These two vaccines, I don't think so any middle class, lower middle class countries will buy it. That will come in the private sector for the top 20 population.
But you know, they say the Pfizer or Moderna vaccine is different. Moderna doesn't need so much lower temperature, like as Pfizer is. They need more than.
But the indication recommendation will remain the same.
No, I'm just asking why the people go for Pfizer vaccine, because it needs a special temperature. So if there is no superiority, then why the people will go for that? Do you have any answer for that?
At the moment, Moderna has not declared their similar copies as Pfizer has done it.
No. Last night I saw that the Moderna doesn't need so much.
That is for the transfer, but efficacy and other things we need to see. That is, Moderna is saying -20 is okay.
Yeah.
That is a different issue as far as transfer is concerned, but we need to see the efficacy.
Yeah, but I know, but you know, the question is asked here because in this country actually cannot afford such a lower temperature for transporting the vaccine. So that is the question.
Like India, Bangladesh, and Pakistan.
Yes.
We will have vaccine will be whether it is Moderna or whether it is Pfizer. It will be available in the private sector only. For the top people, it will be available. Government will not buy them.
Yeah. Okay. Interestingly enough, one of my colleagues is in the is in the vaccine committee in Singapore, and she said that the anaphylaxis cases in the Pfizer vaccine is actually due to the liposome containing PEG. PEG is polyethylene glycol. That's the stuff we use to clear the bowel for colonoscopy. So it's quite interesting. And that's why there's a recommendation for observing the patients for 15-30 minutes after giving the vaccine.
Yes, I agree. It is an
so this is something everyone has to watch out for.
What I'm trying to say is whether it is due to whatever it is at this moment, it is causing an anaphylaxis reaction. So therefore, you have to be very clear in your preparation. It has to be given with a anaphylaxis control program. Then only you can give to any patient.
Yes.
Thank you. Thank you, Dr. Aguado. This is Elvin from Hong Kong. So it would be great if we could have the PDF slides from you, from the CDC. Thank you. And Dr. Chong, you said, could you just repeat the warning about the PEG in the Pfizer's vaccine?
Okay. Apparently, to protect the RNA strand, which is very, very fragile, you need the liposome to bring it into the body. So the liposome apparently in the Pfizer vaccine has the PEG element in it, polyethylene glycol. That's the stuff we use to clear the bowel for colonoscopy. So, and they believe that the PEG is the one causing the anaphylaxis. So, so there is a warning that there's an advisory that patients should be monitored according to President's presentation, should be monitored for 15 to 30 minutes after the vaccine. Yeah. So that was mentioned by one of my classmates who happens to be in the vaccine committee in Singapore, the one deciding on all the vaccines.
I
So
see.
I have sent the PPT in the NMA group, so all of you can make
Thank
a
you.
copy of it. Ask
Thank
your
you.
people to do some correction, because while copying, I am just checking there was some checkings needs to be done, but this is a copy of the PDF I received. And
Thank you. Thank you.
so whatever, whether it is due to PEG, whether it is any other ingredient, the answer is vaccine should not be given in the clinic. Vaccine should be given in a hospital. Availability of anaphylaxis kit should be there. Patient should be observed for 15 to 30 minutes.
Yes.
I see. Thank you.
And,
Thank you.
and informed consent should be taken.
But regarding the allergic reactions, they are cautioning the person who are having the allergy, severe allergy to the food, to any sort of food. They should be also taken into consideration.
Yes, they're talking food, drug, or injection, vaccine.
Yeah.
So question will come as severe asthmatic, severe allergic. Will they come into not? All these pictures they have not answered.
Yeah.
What about the answer to that question that arises in England, that they're having a severe...
I'm calling today 7 p.m. in my show in Med Talks with Dr. K.K. Agarwal. I'll send you the links. I'm calling one of Dr. Monica Vasudev. She is an allergy specialist, and she will be presenting and discussing only the allergic reactions to possible Pfizer and Moderna vaccine today. So Saurabh can send the link. So she will be, and anybody who wants to be in the show can come and ask her questions. So she is only presenting is how to handle allergies, because she is an allergy and immunologist. So she is only presenting the data on the allergic reactions to Pfizer and possible Moderna reaction. So whenever there is a query, I find out an international expert, call him, discuss with him, and present it.
I will send the link.
Thank you, Sarah. Most welcome. Most thankful. President,
what about the concern actually raised about that severe variant, a different variant in England, whether it will work there also, this vaccine?
Where?
That actually the health secretary of UK has raised the question, not a question but situation in the parliament, that a variant of a separate type of variant of virus has been seen in the southern part.
So let me explain. Let me show you the slide about that, what you are talking about. So we say England. I'll just show you what he is trying to talk about here. Okay. So this everybody wants to know about it. So I made a video out of it, which is available on YouTube. So this is, there is a new virus in south of England, which is called 202012/01 virus. This is called VUI. This is virus unique identification. Like you have HUI, hospital unique identification. This is called VUI, virus unique identification. 2020, 12 means December, 01 means the first variant. Now, what is this variant? There are 3 mutations into this. That is, at the 69th amino acid, histidine has been deleted. And at 70th amino acid, valine has been deleted. So there are 2 genes which have been deleted. One gene has been substituted. N501Y means on 501 gene on the RBM receptor binding domain of the spike protein of the coronavirus, instead of N, which is asparagine, Y, which is tyrosine, has been replaced. So there is a replacement. Instead of N, there is Y. and 2 genes have been deleted. So far, more than 1,000 cases have been detected, and they are saying after D614G mutation, N501Y mutation is the new mutation which is now going to spread in the world. Again, more contagious, less severity. So whenever there is a new mutation, wherever there is a new mutation, the purpose of the new mutation is to go make the disease endemic so that the virus can stay in the universe forever. So therefore, every mutation you will find will be more contagious. So previous D614G mutation was a single gene mutation. This is a 3 gene mutation. 2 genes have been deleted, and in 1 gene, there is a replacement or the substitution of 1 amino acid. I think that answers the question.
President,
Yeah,
will this
no,
will this affect the vaccine efficacy if these
No, it will not
mutations?
affect the vaccine efficacy because these are variants, not the new strains. Because these mutations, thousands of mutations have already occurred. When you photocopy a machine, you can make an error. So this is this is the latest new variant. Remember the word strain and variant. Strain means dengue has 4 strains. Dengue 1, dengue 2, dengue 3, dengue 4. These are called strains. Strains are different than variants. Variants are single gene, 2 gene, 3 gene mutations. When these variants become so important that it changes the behavior of the virus, then it becomes a strain.
but my question is why the concern has been raised in the parliament.
Yes, the concern has been raised is because reinfection can come. We have cases of D61. When you have reinfection, so reinfection can come with the new strain or new variant also.
The concern has been raised also about the vaccine.
Yes, absolutely. Vaccine, as on today, they say that vaccines should not, see, every year the vaccine will be different for that everybody should remember, like a flu vaccine. Every year the vaccine will be different because the variants will go on changing. The variants will go on changing.
President, thank you very much for that very enlightening, filling in of information. I must admit, all our immunology has been brought up to speed by you.
Thank you.
over the last several months. I must admit, amazing. So thank you, President, for doing all the hard work. All that reading and all that.
You can call yourself as immunologist.
Yeah, I think our immunology is really up to speed right now. Thank you. But so necessary, when this crisis has really shown us that we really have to be, well informed of immunology. I'm afraid, there's no going back from here, because in the next few years we'll expect to have more of these.
I'm making a panel of physiologists, biochemists, and microbiologists, and I'm going to devote the next full year into cellular physiology, which will include everything there.
Yes. And
Dr. Agarwal, Dr.
Yes.
Chong, if we are finished about the vaccination, the question I raised at the beginning of the meeting, can I just get some sort of answer for that?
Please repeat the question.
Yeah, because in Singapore, you have shown that the contact tracing is very stringent and very.
Yes.
And that question has arisen whether the privacy is concerned there.
Okay.
Privacy, yes.
So we have an app called the Trace Together app in Singapore. It's on the phone, and this app.
But does it interrupt the privacy? Question of privacy of the people.
Okay.
Or it is protected by the law.
Okay. So we have a very powerful PDPA Act, Personal Data Protection Act here. So that is so when they built these apps, this built by the government, of course, they took all this into consideration. So the information will only be used if the patient becomes positive. That means if the patient is infected, then they'll use the data. They'll call the data and use the data. So I'm trying to find my app right now to show you. There's two things I think I showed you all before. There's a token and an app. So the token is a little green token, which you can carry around all over Singapore. And the app and the token both talk to other tokens and other apps via Bluetooth, right? And they all exchange information with each other. So they meet, when you meet each other, when the tokens meet each other or the apps meet each other, they'll exchange a handshake. So all this information is captured. And sometimes in a day, I see that my app has met, my phone or my app has met several thousand other apps, other people in a day. So even when I walk through a mall, my app is talking to all the other people's phones. So in some days I'm surprised, but I actually looked at the app and it tells me that I actually have met several thousand people. So which is quite amazing. But like I said, the information is only used if the patient becomes positive.
So one thing is very clear, Jamal. Remember, this is a pandemic act. And in a pandemic, there is always a broader good versus confidentiality. Okay. So when it comes to a pandemic act, or every country should have, maybe having a pandemic act, we have a pandemic act. So in a pandemic act, broader good becomes more important, not the individual privacy. So any notifiable disease means no privacy is there. If you declare a disease as notifiable, how can notifiable and privacy be together? They have to be discrete to each other.
No, but the thing is the tracing, the continuously tracing the movement of that pair. Hello.
Can I
I'm saying now, this is a broader good. So therefore, I'm talking about privacy versus broader good of the community. It's a broader good. When it comes to broader good, community can take any action. It is a law.
Can I just show you that?
But I told you that the question has been raised here, actually in that meeting. That is whether we are concerning the
What was the answer? What was the solution? What was the answer given?
No, there was no actually. It was just discussion actually. Concern has been raised.
Can I?
Whether in Singapore, the people are raising the question or not. That's interesting.
So far, I will tell you that the government is very clever. So they told us publicly that if 75% of the population uses these things, this token or the app, right now it's 65%, we're 10% short. If 75% of the population uses these tokens and apps, they will liberalize further. So they have told us that this is their thinking. So we are 10% away from the optimum coverage, which is estimated at 75%. So once we hit 75%, there'll be more liberalization of the rules. So I'll just like to show you this. If you all can see from here, it tells me that the last 14 days where I have been is safe. All right. It tells you the last 14 days where I have been is safe. And then look at the records. Very interesting. Can you all see the number of Bluetooth exchanges per day? 1,000 and so on. You can see. So this app is talking to many other people. So this is a very interesting piece of technology. So on the average, I'm doing 1,000 Bluetooth exchanges every day for the last few days. So which I mean, I don't even realize, right? Because I'm just walking, going for lunch or whatever, wearing my mask. But actually, I'm talking to 1,000 over other apps, other people during a course of a day. So I think so far our population here, of course, we are very obedient, I must say, having been trained by Mr. Lee Kuan Yew. So, but I think it's really quite a useful technology. I hope I've answered your question, Jamal.
Yeah, thank you. Yeah, sure.
So, Chair, I would like you to now ask everybody to speak a little bit.
Yes, please. Okay. Alvin, would you like to say something about the situation in Hong Kong?
Well, In Hong Kong, excuse me, can you hear me?
Yes.
Yeah. In Hong Kong, we do have the problem of the fourth wave, and which might cause the mutated virus. Just now we had mentioned it's more contagious, and it's a lot of interference, etc. Is it okay now?
Yes, it's better. Yeah.
Two very young patients had suffered and died from COVID-19 for the past week. There's one individual, 38 years old, but he's of course a sufferer of a comorbid long chronic disease, long-term disease. And but still, it seemed that for the past 2 weeks, some of our fatalities occurred in younger people. Just 2 days ago, there are two persons, one 56 years old woman, another 63. So 56 and 63-year-old women who had died before going to the hospital, entering the hospital, and just dropped dead.
Wow.
Before the results of the COVID-19 tests were available. So that's horrible. And of course, the population scared and raised alarm to us. And then another thing is that one patient, 61-year-old man, had been admitted into the hospital and isolated in an isolation ward, and yet he ran away.
Oh,
he ran away from the hospital, and that's something alarmed us. And Jamal, what happened if this occurred in Singapore or in Bangladesh? Would the privacy issue more important, or the safety of the population at large more important? So I think so it just occurred last night, and in fact, the hospital authority in Hong Kong still protected the person's privacy, not revealing to us his identity, not revealing us his name and his picture. I think this is almost, well, it's illegal for him to run out of the isolation ward. In fact, I think his privacy is not superior to the safety of the citizens in the population. So we have urged the hospital to expose his identity, his look. I mean, so after this event, in fact, I also advocated to urge the government to have the WhatsApp development like that in Singapore. I think that is quite important. Now, the police still could not find the runaway man.
Oh my goodness.
He's still in the population running around. So my goodness. So that is so dangerous. So I think privacy has a limit in our society.
Elvin, can I ask you about, remember you talked about how some exemptions were given to certain populations, and that's what resulted in several waves. Can you talk about that?
Oh, yes, that is a recurrent mistake for our government. So it is the exemption for the change guards of the sailors in this third wave, when at the end of June, 9 sailors from the Philippines who had carried the mutant gene, that is the D614G, you mean, entering into Hong Kong because they are exempted at the border to be tested for the COVID-19 and then exempted for quarantine. And so they entered the city traveling in the taxis and spread the virus all around causing the third wave in July. So in September, at the end of the September, there was 17 Nepali passengers entering Hong Kong, and again traveling to the city by taxis, and they were exempted from testing at the border and quarantine. Again, now they are not sailors, they are not crew members, I suppose. They probably are some higher rank consul general officers from Nepal. So they were exempted again because of these political politeness and respect to the consul general people. So again, that came the fourth wave, and so it's detrimental to our economy and to everything, because everything had to be locked down again. All the businesses and our travel bubble between Singapore and Hong Kong dropped. Oh my goodness. So that's how our fourth wave came out, and still now it's still at the plateau. We still had about 80 to 90 confirmed cases every day, of course, although some of these positive cases are asymptomatic. They are positive by contact tracing. But still, that is, the virus is running around in the city, and about 20 to 30 every day confirmed positive cases were without any known origin, and that is not contact trace possible. But then it's still so I don't think we will have festive celebration for the Christmas season or the New Year season. So I guess we will have silent nights and silent Christmas and New Year to celebrate.
Sorry to hear this, Alvin, about all these exemptions causing so much problems, and this patient running away from the isolation ward. I think Marie cannot speak today. She just put on the chat. So I'll ask Professor Ashraf whether he has anything to say. Professor?
Professor muted.
Yeah. Thank you very much.
Okay.
Thank you very much, Sean. Pakistan, frankly speaking, we are now passing through a very critical condition over here. Although the government is trying to get the vaccination and trying to do, because the number of the patients that is very high at the moment in Pakistan and getting worse day by day. The reason behind is that the attitude and behavior of the masses or the public, we are having a very political parties, activists over in Pakistan, which are now facing difficult times, and the society and the government, up to some extent, have not been succeeded to make the people aware about the seriousness of the disease. But having said, but still Pakistan is in a position to control the disease. The hospitals and the clinics, they are well maintaining this situation. And hopefully now, what is the condition? That is the vaccination. About vaccination, Pakistan is a liberal country in that sense. We are very closely working with the Chinese indigenous vaccine that is also in progress in Pakistan. There is that going third trial over here. And about the American vaccine and the Moderna vaccine, Oxford vaccine, the private sector is over there, and the government is also trying to get these vaccines as soon as possible for Pakistan. And Pakistan is expecting that within the 2 or 3 months, the vaccine will be available in Pakistan. With the Chinese, as the Pakistan Medical Association, we are working very closely. We have the sample of the vaccine over here, about 20,000, and we are trying to increase the trial, the third trial over here in Pakistan, in Lahore, in Karachi, and all over the Pakistan over here. And we expect that we will get the vaccine. The Russians, they have offered Pakistan to sell out their vaccine to Pakistan, and government is considering having some trials, the efficacy of the vaccine by the Russians, and hopefully the situation will be under control soon. But it will take, certainly, as Alvin was talking about, the Pakistan, it will be able to control this disease or to provide the vaccine. It will take, to my understanding, about 4-5 months in Pakistan. We will remain in a critical situation. And the worsen as far as the temperature is over here. So the situation is again the worst. Thank you very much.
Yeah, I noticed all my colleagues from the subcontinent are all wearing scarves.
Yeah.
So it must be quite cold. It must be quite cold there. Yeah.
Cold, not quite. It's 60, 70
I
degrees.
want to pass
Yeah.
one resolution today,
Yes.
Chair. I want all our CMAAO member countries office bearers, whenever they get the vaccine, a photo should come back on CMAAO website, a copy should be sent to me, because we
Okay.
want to promote people to vaccinate. We want to be against people talking against the vaccine. So we as a healthcare professional
Yeah.
wants to, we don't want to, so we want to spread out a message. No doctor should say, I don't know whether the vaccine will work or not.
Yeah.
No doctor will say, maybe. No doctor will say, I'm not going to take it. No doctor, if you don't want to take it, don't speak out. That's your personal choice, but don't speak out, because if a doctor says, I'm not going to take it, means public will feel the vaccine is bad.
Yeah.
So therefore, we create an appropriate resolution, which we can put it and we can promote. And I will request all of us, when we take our vaccine, our picture should be projected in the social media everywhere that I also have taken vaccine.
Yes.
So if we can send a letter to everybody, if all the CMAAO countries can take a vaccine and project our pictures, a message will go to the community, because there is a lot of confusion in the community. And the confusion will not come without talking to the doctors.
Yes.
Because the doctors will say, I don't know, let's wait. Then there is not enough data. So that's the reason of me projecting this data today very clearly, so that all questions are answered with that. Still, there is a professional autonomy. Still, there is a personal autonomy. India has come out with the guidelines, no mandation, but advisable.
Yes.
But advisable.
Prof Ashraf, do you have any thoughts, or do you have any anecdotal experience with the Chinese vaccines in Pakistan? Is there any feedback from your colleagues who are running the trials and so on? Is there anything? I'm just curious.
Yeah, thank you. I'm also very closely working on this Chinese vaccine. Hence,
Okay.
we are working through the University of Health Sciences in Lahore. I'm working in the government sector, and people, they are having this vaccine. And luckily, we have no complication where the vaccine has been trialed and vaccine has been used as far as the trials are concerned. So Chinese trials are positive, and we are now in a phase to compile all our results. And soon, I believe within a week or so, we will be unable to calculate all the trials in Pakistan, and then I will come back to you, inshallah.
Prof Ashraf,
presently, there
what
is no
vaccines are being tested there? Prof Ashraf, what Chinese vaccines are being tested?
These are the two vaccines. One is produced by the Chinese government, and other is the private sector over there. And what we are using, that is the Chinese, and Agarwal has talked all about the vaccines, what the Chinese are producing. To be very frank, in details, in depth, I have not studied all these, immunological or the deep studies of this vaccine. And simply about that as an orthopedic surgeon, not as immunologist.
Let me answer from Ashraf. Hello, everybody. I'm Dr. Professor Ashraf Nizami, the president of Pakistan Medical Association, speaking about, I'm replacing you for 2 minutes as Professor Ashraf Nizami. So the Chinese vaccine is a inactivated, killed vaccine. So whenever there is a killed vaccine, it is like a dead virus in your body after the virus is non-replicating and producing antibodies. it is supposed to be least, it is supposed to be the safest vaccine, and it is supposed to be thus producing less antigenicity. So therefore, its expected antigenicity should be 60%. And if 100% of the community is given this vaccine will take care of it. This vaccine is, suppose it is if it cause viral infections, if it cause any complication, the complication will not be other than the virus can produce. So if a virus produces transverse myelitis, then this vaccine can also produce transverse myelitis, but that will be a mild transverse myelitis. So if a patient gets any complication, the complication will be a milder type of a complication, which otherwise he would have got if he would have got the natural viral infection. So in any pandemic situation, inactivated vaccines are called as a bridging vaccines till a more efficient vaccine comes. I think both India, Pakistan, Bangladesh could have started this vaccination much earlier. But fortunately, what is happening is in India, Pakistan, and Bangladesh, we will see herd immunity much earlier. The data which shown in India, I can give you Indian data. For every one patient who is symptomatic, there are 90 asymptomatic cases. This data was 1:25 in New York, way back when the first wave started. This data was 1:30 in Hong Kong, China, wherever they do, the ratio is 1:30. For every symptomatic cases, there are 30 asymptomatic cases. One DST data which has come is DST data which has come a couple of days back shows in India 1:90. This is in some states it is 1:60, in one state it is 1:300. In September it was 1:60. If I take that into consideration, India requires only 20 to 30 crore, which is 200 million, more people to get the infection to get the herd immunity. So if 20% of the population is given the vaccine, we expect the herd immunity by 25th of March, which was the first day of lockdown in Delhi, in India. So we expect within a year, India may be able to achieve, maybe the first country to achieve herd immunity without 60% of vaccination. All other countries will achieve herd immunity by 100%, America by 60%, Hong Kong and China, Hong Kong, they will have to have 100% vaccination to acquire. If they are taking Moderna, then 60% is fine. But non-Moderna will require 60% of the vaccination to cover for the herd immunity. So I think Professor Ashraf, Dr. Professor Ashraf, I am of the view that it is a blessing come disguise that the problem in Pakistan is increasing. And as long as the mortality doesn't reduce, it's fine. We are going towards herd immunity. So now I again become Dr. K.K. Agarwal. Thank you, Dr. Ashraf, for explaining this.
Thank you very much. Thank you.
I have a
Thank
question
you.
to Dr. Ashraf.
Scientifically.
Professor Ashraf,
Thank you, KK.
Professor Ashraf, can
Yeah.
I just exchange one view with you that you are raising the point of the political activities at the gatherings actually, which are increasing the number of patients. In Bangladesh also similar things are going, and because the people are not scared that as they are what we are expecting from this gathering, we are not getting it. That means the number are not increasing so much as we are expecting. So do you have any explanation for this, or do you have the similar situation in Pakistan?
Dr. Chaudhary, one thing what I share, because we have been failed as association or as government, the masses, the public, they are still feel that there is no COVID-19, there is no corona, and these are just the doctors and the government and the international media, which are, talking about this such a disease or such a virus. And so that is the attitude and behavior from the public. That is one of the main reasons. as far as the control, and KK has already been said about it, that we are having the herd immunity over here in Pakistan, and there are certain studies which shows that we are on at the verge of 40 to 60%. There is the herd immunity in Karachi and these. But having said, still it is all in studies, to be very frank. But how it is going to happen, because we are on a hype, and as you know that it will reflect after the 14 days or 10 days, that how the reaction of these actions which have been in public gatherings and so on, and that's what we are expecting about after 2 weeks and so on, that how it will be the answer. Then I think, but luckily, as far as the government is concerned, the private institutions are concerned, we have a better preparation over here in Pakistan, and still we are coping with all the situation, which is about the COVID-19 patients, but not in a good shape. Not in a good shape. We are worried at health professionals.
Thank you, Professor Ashraf. Doctor, maybe I just ask Dr. Prakash whether he has anything to say. I see him there on our screen. Dr. Prakash?
Yeah, thank you, Dr. Chair and President and all the national delegates. Because in Nepal, nowadays, the infection is decreasing, but the severity of the case is increasing, because 80 to 85%, because 80 to 85% infected case are in home isolation, and the time to reach the hospital is becoming very late, and most of the hospitals isolation bed are empty, but the ICU bed are all full and packed, and death rate is also increasing, and that's why now we are again going back for the isolation of the positive cases in hospital also, because the home isolation is becoming risky. And the second thing is the vaccine. In vaccine, I think in Nepal, the first vaccine will be by March from the COVAX only, because the Chinese and Russian peoples are in Nepal for their vaccine lobbying, but still we are asking them to give all the research details, whatever the clinical trials, whatever the procedures they followed, and the details of that, and still they are not able to produce these things. That's why I think the government may not buy the vaccine before the COVAX facility, and that's why now the first wave is we are decreasing, and but the winter is increased. That's why the cold weather becoming the might be the risk of the second wave in Nepal. We are thinking that way, and we are preparing in that way also. Thank you all.
Thank you, Dr. Prakash. Most thankful for your update.
So we have the South African president that are also
yes. Angelique, would you like to say something?
Thank you. No, I can't start my video. I'm still in bed.
It's okay. It's okay. It's okay. Welcome.
Yeah, I unfortunately had the time wrong. I thought it was 6 o'clock in South Africa. I only see it now 7 o'clock. So I forwarded you, Bo, to this group what happened in South Africa and the mutation with the new variant that we have, which is much worse than the first COVID-19 virus. I don't know how to explain that, but there's definitely mutations, and the second wave that we are now seeing is worse than the first, and it's more it's faster, and it's going to cause more disease of the clinical picture than the first one. the press medias that we have sent, we have decided not to, to just sort of play it down that it's not as bad, but we want our media and our people to begin to understand there's a new variant, but this is actually much more aggressive than the first one. And I think you guys need to look at this, and because that can also be the case if you see more virulent viral infections of the COVID-19. And that's it. That's my my contribution to this morning. Is that's actually very important what I've sent to you guys. Thanks.
So this is the same 501 mutation, what she is talking about. So this is a new variation declared 24 hours back, that a new variant is spreading very fast. And that's also a 501V2 variant. I think it's the same variant which is in South England, so which has reached there. But they are calling at the moment it as a 501V2 variant. So I will go more about it. Most likely it is the same virus which is spreading in south of New England. Remember the word 604 and 501. 604 was earlier and now is 501. That's a new variant of the virus which is acting on amino acid 501. So Kanaz, are you from where you are, Kanaz? I don't know, because there is a word coming Kanaz. So we'll ask Dr. Mathinda Pillai to give the final word and then the chair to close. Already we are late today. Dr. Pillai.
Thank you, KK. Your presentation was very educative and up to date, and definitely gave all of us some direction, medical persons, as to how to move forward. And you have already said that the status of the vaccine in India, the government is now sort of taking the list of a high-risk population, aged with comorbidities, and also taking into consideration whether they had some infection or not. And the list is almost in the final stage. And at any moment in India, the immunization process can start off. But the information you have shared with us are very, very vital. And also your message that medical persons has to support vaccine and not be sort of evasive about its impact and its need. And that message is very, very important. Unless the medical profession stands for the vaccine, the people may not accept it, and crores of rupees that is going to be spent on it may become a waste. So your deliberations have been very useful. Thank you.
So I'm just reading about in the UK. This is a writer's study. In the UK, they have also identified a new variant. There are quite a few similarities between the two lineages. There are also a similar number of mutations that has been declared. So this is both of them have 3 variations. Both of them involve the same gene. So, but they may be slightly different. So there are 2 different types of mutations which are absolutely similar to each other, one in south of England and one in we have in South Africa. Over to the chair.
Thank you, Press, and thank you, Dr. Pillai. And today has been a very informative session as always. Thank you, President, for updating us on the immunology of the virus and all the latest recommendations on the vaccine, the Pfizer vaccine, because it really there are, I think, questions in every doctor's mind as to the safety of these mRNA vaccines, because these are also new, and understanding the immunology is really important. Understanding how this mRNA works and how it's deactivated and so on, doesn't go to nucleus. I think all these are very important to put us all at ease, so that we can feel confident about taking the vaccine ourselves and then setting an example for the population to follow. So I think it's very important. The other thing is we also had a nice little discussion on privacy issues, confidentiality issues versus tracing apps that can help us to control the epidemiology of the virus, because we not only need the vaccines, we also need to control the spread of the virus. So that's also been a very useful little discussion. So I'd like to call a close to today's discussion because we're running a bit late. And I look forward to seeing everybody next Saturday for another robust discussion. Thank you all for participating.
Thank you. We'll see you back.